Hi, today we are going to talk about an approach to akinetic rigid syndrome. So, what is an akinetic rigid syndrome and how am I going to cover up in this session? What I'm going to do is I'm going to use what I would like to coin a term as called the mean method, where we're going to talk about the meaning of what is akinetic rigid syndrome. I'll give you a few examples. Then I will culminate them into a single approach, how to approach a case of suspected akinetic rigid syndrome. And then we'll end up with some nuances to keep in mind. So how do we define akinetic rigid syndrome? Akinetic rigid syndrome are a cluster of symptoms. Basically, it's divided into two terminology, akinesia or akinetic and rigidity. So what is akinesia? Akinesia is interchangeable word which composes of three components. One is bradykinesia. Bradykinesia is slowness of performed movements. The activities what you're doing, you're slow, but of full range. For example, you're holding a fist and opening. You are doing it full, but you're doing it at a very slow pace. And then you have hypokinesia. Hypokinesia is you're not able to do the range with the full movement. Means you're doing at a smaller amplitudes than the required amplitudes or required range what has to be done. Then we have someone who has akinesia. Akinesia means no or to poverty of spontaneous movement. That's what we should keep in mind. So any person who is having combination of these symptoms, many times these are all exclusive terminologies in their own meanings, but most of the time it is used interchangeably as bradykinetic symptoms or akinetic features, depending on the context, depending on the situation. So that's what you need to keep in mind. Then comes the rigidity part or rigid part. Rigid is due to the stiffness due to increased tone in both agonist and the antagonist muscles. This can be in two varieties, the rigidity. One is lead pipe, where you feel the stiffness whole throughout the same way, like you're stretching a lead pipe, or it can be cog, means you have jerks of release, stiffness, release, stiffness, release, stiffness, release, like a cogwheel appearance can happen. Please do remember that rigid is different from another increased tone, that is spasticity, where there is only one set of muscles are contracting more as against the other set of muscles. So today we are going to talk about where we have symptoms where both akinesia and rigid are there in a given person and they are presenting to us. When we go into this, the classical examples, when we start working on akinetic rigid syndrome, this is the table what we get. If you have read through, or those people who have not read through approach to akinetic rigid syndrome, the classical example of akinetic rigid syndrome is Parkinson's disease, where people will have stiffness, slowness, and postural instabilities. However, some people may not have may have symptoms of Parkinson's disease, but they don't have actual Parkinson's disease. Their response is not similar to that, and they have associated other features. Either it may be in the form of vertical gaze palsy, dysautonomia, cognitive issues, behavioral issues. So we call them as Parkinson plus syndromes. There may be set of patients who don't have classical degenerative disorders which either fit into Parkinson disease or Parkinson plus syndromes and are caused due to various secondary causes. And these are termed under the terminology called as drug-induced Parkinson's disease, metabolic, or secondary Parkinsonism include vascular Parkinsonism, trauma, infections or post-infectious cases, toxic, space-occupying lesions, and immune-mediated lesions, just to name a few answers. So this is where our classical understanding of Parkinson's disease, Parkinson plus, and secondary Parkinson's or akinetic rigid syndrome comes into the picture. Today, I'm not going to go into details of each one of these things because these are the very classical disorders what we should be knowing when we talk about akinetic rigid syndrome. There are specific talks or sessions which will be which are specifically addressing these specific disorders over the next few days. So let us see some of them, try to understand what do we mean. And I'm trying to build up a context here for you people to understand that what is required and how to approach a case with a suspected akinetic rigid syndrome. Let's see, here is an example of 45-year-old person who is coming to us. This person is having 1 to 2 years history of slowly progressive akinetic rigid syndrome, slowness, stiffness, which started from one side of the body, that is unilateral, and then slowly evolved to bilateral syndrome. Concerning other neurological symptoms, no other concerning systemic signs, primary history. However, when Europe was given to him, he had a good response to when we see classical history at this type of patient, the first diagnosis what it comes to us is Parkinson's disease. And this is what we should remember when someone talks about akinetic rigid syndrome. Parkinson's disease is the first and a major type of an akinetic rigid syndrome. Henceforth, I'll be taking this as a standard template for all my cases. I'll be going each one of these cases, like age of onset, keep the eye on the age of onset down there, temporal pattern, body distribution, associated neurological signs, systemic signs or symptoms, family history, drug or treatment history, and imaging findings. I'll take this as a template to talk about various akinetic rigid syndromes. Let us go to case 2. Case 2 is a person who is around 60 years old. 1 year. Onset of symptoms, slowness, significant balance, okay, associated symptoms of signs, no family history, has been treated with various medications, and there has been no significant benefit with any of those medications. MRI brain done shows midbrain atrophy, classical Mickey Mouse sign, and change in the midbrain to Pons ratio. So what is our classical thinking about this? This patient, we know that now, patient is having akinetic rigid syndrome, however associated with vertical gaze palsy, and we would like to call it as PSP or progressive supranuclear. There are 10 different varieties of PSPs are there, but we'll go through them later. Now coming to case 3. Case 3 is another middle-aged lady who has presented with acute onset of almost predominant akanesia and slowness and rigidity without any other neurological symptoms. There are no other systemic signs and history of cardiac arrhythmias are present. MRI brain done has acute infarct without any other pre-existing comorbidities. So we know that this patient had an acute onset of akinetic rigid syndrome. Now we know that this acute onset of akinetic is possibly related to vascular event, what has happened. We call it as vascular Parkinsonism. The cause of akinetic rigid is vascular event. This case 4 is the commonest case what we see. Is once again a middle-aged person who is presenting with subacute onset with almost symmetrical features of slowness, stiffness, and tremulousness, clinically appearing of akinetic rigid syndrome or a Parkinsonian syndrome. In addition, patient also tells that she had been having long-standing history of gastroesophageal reflux disorders and has been on long-term usage of leosulfide for her gastroesophageal reflux. MRI brain is normal. So as soon as you come see a patient with Parkinsonism, it's very difficult to ask for drug history or treatment history. And many times people miss to tell them over-the-counter medication use utilization, especially when it comes to antacids. In this patient, we know that this is more likely liver sulfide-induced Parkinsonism what patient has done. So this is a drug-induced Parkinsonism or drug-induced Akinetic Rigid Syndrome. Coming forward, here we see a patient with for middle-aged person who is presenting with subacute onset, almost similar to Akinetic Rigid Syndrome, associated with disorientation on a background of urinary tract infection and dyselectrolemia. He had hyponatremia, which was rapidly corrected, and following that, during this stay in the ICU, he had developed Parkinsonian syndrome, which was not pre-existing. An MRI brain done shows features consistent with osmotic demyelination features. So we know that this is a metabolic syndrome which has occurred either due to hyponatremia or post-hyponatremic correction-related issues. So metabolic induced Akinetic Rigid Syndrome. Coming to case 6, here we see a young adult who presented with
Segment shows the patient with reduced steppage gait, hypomimic myopathic-like facies, absent arm swing,
where he's having slow
and tremor in the dependent right arm.
mild tremulousness. Along with that, he also has cognitive changes, pyramidal features, ataxic features, behavioral changes, nystagmus, oculogyric crisis, neuropathy findings. I'm just giving in a crux of
When
findings.
seated, the right upper limb tremor is present
Easier
and
understanding of
reemerges under a short latency when the arms are held in
other
posture.
associated systemic signs are there. There could be a family which is not very clear. It has been taken with MRI brain done
Spinal bradykinesia, a palm finger, and
Coming to case 7. Case 7 is a 20-year-old young man coming with sudden onset of symptoms, almost sudden onset of symptoms within few minutes to hours, where he has developed a kinetic rigid syndrome along with associated with having dystonic features, which has a rostrocaudal distribution. Means you feel more dystonic features are in the face, then followed by the trunk and the limbs and the lower limbs. There are no other associated signs or symptoms. No family history is available in this case. He was treated with levodopa with some response. He was treated with levodopa with no response. MRI brain was inconclusive or no specific answers we could get it. So this is a case of rapid onset dystonia Parkinsonism where genetics has proved that he is having ATP1A3 mutation. Case 8. Case 8 is a adolescent or early adulthood person who has presented with subacute onset progressive akinetic rigid syndrome in the form of slowness, stiffness, and there is also almost symmetric involvement of symptoms along with some history of dystonia is there, behavioral changes are there. There are no associated systemic signs or symptoms. Was not helpful, and MRI brain, a regular MRI brain, was within normal levels. This patient, we know that when the genetic testing was done, came as positive for PLA2G6 mutations. Coming to case 9. Case 9 is a second decade onset where we saw a person within 20, almost around 20 years of age with subacute onset, progressive symptoms with bilateral body
Patients show
distribution
walking and
of
has some steps
slowness,
to
and
pivot, but
along with
otherwise
that there is eye
ambulate
movement
well.
abnormalities and ataxic features are there. Systemic
Okay,
signs
normal,
and
eye movement.
symptoms are none. There is strong autosomal dominant family history of spinocerebellar ataxia is noted. Drug treatment history is negative. MRI brain done shows a cerebellar approach. So it's very clear that here the cause of presentation of akinetic rigid syndrome is secondarily related to spinocerebellar ataxia. So one of the causes for akinetic rigid syndrome we should keep in mind is spinocerebellar ataxia.
Testing for bradykinesia shows
Going forward, for the last example, that is a young onset or around 12-year-old person, child, who is coming with subacute onset progressive symptoms of akinetic rigid syndrome in the form of slowness,
the
stiffness,
facial expression and
poor
speech in this
scholastic
patient are
performance
reported as
along
normal
with
by
that,
the authors.
and without
However, there's
any
moderate
other
bradykinesia,
associated
jittering,
signs of
and mild action and postural tremor on
family
the right
history
side.
is considerably
Decreased arm
significant
swing
with
and dystonic
autosomal
posturing
dominant
of the
type
right arm
of
will be noted in the
penetrance
patient
with
card.
clinically diagnosed Huntington
There's
disease.
slowness of movement also
Drug
on the
and
left
treatment
side,
history
but it is
negative.
much more prominent.
MRI brain done has been within normal limits. So here, on the background of family history, with the onset of akinetic rigid syndrome in a very young onset,
Clapping
we are more
movements
comfortable to
can be
consider
done.
a diagnosis of
But
akinetic
on the
rigid
right,
syndrome
They
most
are
likely
reconstructed with much more
related to
bradykinesia and also
Huntington's
intermittent
disease.
tremor.
So this is the case of a Huntington disease,
Foot tapping,
juvenile Huntington
slow
disease,
on the left side,
presenting as a
but more
akinetic
influence.
rigid syndrome.
as you will see on the right.
So what did we saw here? In all these 10 cases what we discussed now, we went through various different types of cases occurring from 70s to 60s to 50s to 40s to 30s to 20s to 10. So every decade of life, we have found different types of causes for akinetic rigid syndromes, which can be acquired or which can be genetic. There are so many other disorders also, which I am not been able to cover up here. But just to give an example, some people can have behavioral variants which are specifically not fitting here.
Yeah, so worry about this one, but the brown guys are in that pointing out for some.
People can have very early onset, especially like GCH1 mutations, hydroxylase deficiency mutation, where people can have once again a clinical picture.
6 months old girl. This stage, soon after starting the adult therapy, to sit position, no extreme head lag.
The exhibits bradykinesia, mass-like faces, mild left tremor of the mouth.
Approach this case. So what do we know about? So it has been looked into it. It's not like the patients, when we develop akinetic rigid syndrome, what is the probability of seeing anything? Forget about secondary causes, which can be variable based upon geographical and other factors. Is there a genetic pattern into it? A nice publication, which has been published in the Brain in 2020, where they have seen from around 219 articles published, where they included only young adolescents or less than 21 years of onset of patient. They got 407 patients with akinetic rigid syndromes. Among these 407 patients, they noticed that there are about 60 different genetic conditions were there, and among them, around 70% were autosomal recessive, a quarter of them were autosomal dominant, and a small percentage, that is around 3.5% were X-linked disorders, and another 0.5% were mitochondrial disorders. Surprising, what we should also try to remember here is, among these 407 patients, where levodopa responsive results were available in around 250 patients. About 98 patients had excellent response. That means almost 60% of the people. Moderate response was noticed in another 80%. Mild or no response was noticed in around 71%. I've just given some examples here how authors have classified based upon the commonly seen genes as infancy, which is less than 2 years, childhood, which is between 3 to 12 years, and adolescence, which is 13 to 21 years. Even though some of the genes are overflowing into the other groups, but the frequency do vary from different age groups, what we are saying. So it does tell that there are different genetic disorders are common in different age groups. And this helps us to, when we try to approach a case with suspected either autosomal recessive, autosomal dominant, X-linked, or a mitochondrial disorders, to decide on what we are looking forward for. So knowing all those things at the end of this is we need to have a clear approach. That's the whole goal of my talk here. So how to approach? Akinetic rigid syndrome, as I told you, my first slide when we spoke about, we know the classical forms. One is Parkinson disease. Now we know that Parkinson disease is not a single gene. So Parkinson's can be monogenic forms, polygenic forms are still undefined where we don't know about it. Or it could be other Parkinson-like or what we call as Parkinson disease-like or commonly grouped under as Parkinson plus syndromes, which includes multiple system atrophy, progressive supranuclear palsy, dementia with Lewy body disease, or even sometimes what we should remember, any type of advanced neurodegenerative syndromes can mimic an akinetic rigid syndrome where the early history becomes very critical. Further, other causes includes behavioral such as catatonias, obsessive slowness, drug-induced disorders, metabolic disorders, tumors, acute infections or post-infectious causes, autoimmune, and space-occupying, which are standard known approach for any secondary disorders, what we will look into it. People can also have akinetic rigid syndrome as a part of genetic defects or genetic mutations, which could be part of syndromic diagnosis, which includes like rapid onset dystonia Parkinsonism, when there is sudden onset rostrocaudal dystonia is there, or when dystonia is the prominent feature, we can look into GLB1 mutation, PRKRA mutation, STAT1, VAC14, VPS13A, Huntington disease, or ATP7B. Or people with associated vertical supranuclear gaze palsy look for myoclonus, pyramidal signs. People with nystagmus oculogyric crisis look for L-DOPA responsiveness, NIIDs, that is neuronal intranuclear inclusion disease. Rapid cognitive decline look for MAP mutations. Psychosis look for 22q deletions or PLAD2G6 mutations. Progressive spasticity or pyramidal features possibly to consider would be hereditary spastic paraplegia syndromes like SPG15 or PARC15, FBX07, PLAD2G6, or associated neuropathies could be there. Then people with ataxias look for spinocerebellar ataxias or mitochondrial disorders. Associated epilepsies could be there, or progressive myoclonic syndromes could be there. Primary chorea associated with akinetic rigid syndromes are there, or even patients with akinetic rigid syndromes with associated epileptic encephalopathies. We have different syndromic diagnoses which can be considered. What I propose, or what I propose at the end of this talk is, for is like akinetic rigid syndrome, we need to go with the current standard way of understanding. First is the clinical characteristic, which is very important for us to know, which is axis 1. As I told you, age of onset. We can tell that because we already know from the brain published article, there are different groups are there. So we can classify them whether the onset is at less than 2 years, between 3 to 12 years, 30 to 21 years, 22 to 50 years, or late adulthood is 50 plus years. Because, excuse me, because we already know that early onset Parkinson disease is classified at cutoff of 50 years. So age helps us to know a different diagnosis. And then comes the temporal pattern, whether it was acute onset, static or progressive, subacute onset or progressive, or chronically slowly progressive. Then you should look at body distribution, whether it is located to one side of a body, in that case of a trauma or a secondary causes becomes very important, or an insult to the brain, or it is slowly progressive generalized symptoms. Other associated neurological signs are critical, which includes cognitive or behavioral changes, associated seizures or myoclonus, associated other movement disorders such as chorea, dystonia, ataxias, or patients may have pyramidal features or peripheral neurological symptoms in the form of neuropathies. All these things are critical. Subsequently, also keep in mind for other systemic findings which can give us a cues. It can be dermatological findings, hepatic issues, cardiac issues, endocrine or metabolic disorders, renal or osteomuscular causes. So if you look into these five clinical patterns of age, temporal pattern, body distributions, other neurological or movement disorder signs, and other systemic signs, you have a axis 1 approach for an akinetic rigid syndrome. Then comes the axis 2, that is the etiological causes. This includes, as we all know, acquired causes. Always look for drug-induced, metabolic, infectious, para-infectious, vascular, autoimmune, space-occupying lesions, and henceforth. So I've just given a few names down there. Then look into, if you don't have any acquired causes, then there may be genetic causes. Whether these are known genetic causes where single gene disorders are there, such as autosomal dominant, autosomal recessive, X-linked, or mitochondrial disorders, or somewhere gene load based mutations, we know that, such as Huntington disease, or neurodegenerative disorders, where some of the cases we know the genes and some of the cases we may not know the genes. For example, Parkinson disease, PSPs, or MSAs. They may be idiopathic in the way that we still don't know the underlying cause. It can be sporadic or familial or genetically undefined at this point of time. So when you take this standard base of approach, you are more likely to have a proper diagnosis, unlikely to miss a treatable disorder. So to remember, to approach the akinetic rigid syndrome, you should go with the clinical characteristics of age, which includes 5 components: age at onset, temporal pattern, body distribution, associated other neurological or systemic findings. Then etiological workup, which should always work up from acquired causes initially, unless until there is a clear-cut genetic cause is already known. Then you go for a genetic workup. Then finally you end up with an idiopathic cause for your akinetic rigid syndrome. Before I end here, I would like to give few nuances to remember about akinetic rigid syndrome. Please do remember that for akinetic rigid syndrome, classically it is Parkinson's disease. Then we have atypical Parkinsonian syndromes, and most of them are neurodegenerative, that is multiple system atrophy, corticobasal syndromes, or progressive supranuclear palsy, or dementia with Lewy body disease, or secondary Parkinsonism, which are our classical group of akinetic rigid syndrome. However, you should remember that these are wide spectrum of disorders where genetic forms of PDs and other genetic and non-genetic disorders are part of this group of akinetic rigid syndromes. These akinetic rigid syndrome can present at all age groups, from birth to all the way to the 8th and 9th decade of life. And different etiologies are common at different age groups. Knowing the age, knowing the temporal onset, you can easily narrow down what type of workup is required for that said person. Also, please do remember that associated features are important. Just having a akinetic rigid syndrome is not a solution here, or not a cure here. It gives a door which have to be looked through every part. And when you look through it, associated clinical findings, either are associated neurological findings or associated systemic findings, may give you an important clinical signs for a proper diagnosis. Always, whenever a case of treatable akinetic rigid syndrome is seen, keep an eye on treatable disorder. That is the clinical dictum what you should follow. Whenever we see any neurological or any medical disorder, primary goal is to first look for workup for a treatable disorder before going up any further. Thank you. Thanks a lot. With this, I conclude my talk on akinetic rigid syndromes. And if any other questions are there, please feel free to ask about the same. Or you can post it to me at my email ID, which is Prashanth.LK@movementdisordersclinic.com. Thank you.